A cardiovascular exam, the bullet points: number 1, palpation of the heart, location, size, or thrills. Second bullet point, auscultation of the heart with notation of any abnormal sounds or murmurs. And then examination of one or more of the following: carotid arteries for pulse amplitude or bruits, abdominal aorta, femoral arteries, pedal pulses, and extremities for edema or varicosity. Very, very easy to hit most of those bullet points in a very quick, short physical exam. Those are what you need to be familiar with. Those are what need to be on your templates. And if you're doing EHR, those things are all built in there already. They thought of this. So we're all going to have to eventually move to EHR. So a lot of this work will be done for you. It'll just be creating a flow for yourself. So here's an example. Person comes in with an upper respiratory infection, and they also have allergies. So these are my questions. The HPI, how long have you had it? When did it start? Signs and symptoms, and the severity. So what are all, if you get a good symptom list, you're going to pretty much cover your bases. Review of systems, cover EENT, constitutional, do you have a fever or not, chest, lungs, and any GI symptoms. That's 1, 2, 3, 4, 5 right there. So that corresponds to a 99214 already. Past family social history. Is it the first one this year? Is it recurring? Do you have a history of it moving into bronchitis or pneumonia? Are you a smoker? That's actually covering past and social history with a couple of very simple questions. For physical exam, you get the vitals, patient's overall appearance, so that's all constitutional, and EENT, and those are the components I get. External ears, what do their TMs look like? Nasal mucosa, sinuses, throat. Check their thyroid because you're already there. Respiration effort, lungs, heart auscultation, and check their nodes. You could do this in 5 minutes, and that's a 99214. So you don't have to make it harder than it is. It can be quite straightforward and not take a lot of time. Our visits, quality and quantity, are not always synonymous. I do spend half an hour with most of my patients, but if someone comes in with a cold, they get added into my schedule because it's acute and they need to get seen today. There is nothing wrong with doing a 10-minute or 15-minute visit, straightforward, get it done, and that kind of makes up for some of my other patients where technically I can only bill a 99204, but I did the time for a 99205. So with insurance, you don't always get reimbursed for every piece of work that you do, but when you throw a couple of acutes in there during the day, you can easily and quickly make up for those other write-offs that you end up incurring. You can't forget the medical decision making, however. So medical decision for a 99213 is considered low complexity. For medical decision making for a 99214 is moderate complexity. Now, the above example, we hit everything we need to for a 99214 on history and physical, but I don't want to just forget about this MDM or the complexity. If someone comes in with just a cold, it's a URI. They're going to get well whether they came to you or not, most likely, self-resolving, so it's not all that complex technically. But luckily, you only have to have 2 of the 3 pieces to get your final level of complexity. So what do I mean by that? Remember I said that medical decision making is how many pieces of data do you need to juggle, how many diagnoses, and the overall